Inequity in Healthcare Systems Worldwide by Sharita Bright. Inequity in healthcare care has been studied time and again. It is commonly the finding of researchers that healthcare disparities are based on religion, race, age, gender, socioeconomic status, level of education, and the place where one resides. Sadly, despite social policies such as universal access to healthcare, greater access to educational opportunities, occupational health efforts, or reductions in income inequality, there have been no significant changes in these inequities. It is commonly thought that America has the worst healthcare system with the most disparities. However, in my studies, I was surprised to find that healthcare disparities exist in modern first world countries such as China, Mexico, and Norway. In China, recent economic growth has resulted in prosperity for the country. However, not everyone in China benefited from this prosperity. As a result, massive gaps in development exist between regions, urban and rural, and social groups. In rural areas, there are far less facilities, and the people living in these areas have suffered. The percentage of births delivered at healthcare facilities approached 100% in cities, while around 60% of births in the least developed rural areas were institutional deliveries. In rural areas, 40% of maternal deaths occurred at home, and 20% were reported to die on their way to the health facility due to lack of a nearby quality facility. The healthcare inequities in China can also be seen in the nourishment of children and the prevalence of mental disorders. In 2005, it was reported that about 12.3% of children in rural areas are underweight, and 17.6% of them have stunted growth due to malnutrition. It is also reported that major depression disorders and severely depressed mood were significantly higher in these children. The Chinese government has been aware of the large health disparity. They have launched a program calling for harmonious society with a scientific outlook on development, SAD. It is expected that by 2020, China will have a healthcare system that caters to all its citizens. In Mexico, the disparities arise from the tremendous difference in income among the people. Communicable diseases are more common among the poor, rural, and indigenous populations. As a result, these groups show higher infant and maternal mortality than the general population. In 2000, 49% of the Mexican population had access to Social Security. This meant that at that time, more than half of health spending came from out-of-pocket expenses. It was clear that the lack of universal health insurance coverage was negatively affecting the majority of the people in Mexico. In 2004, the S&P program came into effect in Mexico. It targets the population without access to Social Security. The SP was created in hopes of equalizing the healthcare accessibility in Mexico. However, despite its positive contribution to increase utilization of services among the poor, a greater investment in health and improved resources allocation had not managed to fully translate into greater equity in health and health care. The fact remains that in Mexico, health care is distributed according to requirements other than one's need. In Norway, there exists a universal public healthcare system based on ideals of equal access for all, according to need and not according to wealth. Although there is universal healthcare, disparities based on education level and household income still exist. The disparities in Norway were not found to be on the part of general practices or in patient services. Instead, significant disparities exist in private medical practices and public hospital outpatient services. This is proved to be an issue because it completely combats the benefits of having universal healthcare. The conflict perspective looks at disagreements within a society and accredits them to the large gap between the upper and lower class. The power in any society is concentrated among the upper class. According to the conflict perspective, the upper class uses this power to suppress the lower class. Looking at the inequities in China, it is clear that the upper class are those that live in the major cities in China. Instead of equally distributing the healthcare facilities, the upper class are selfishly keeping most of the hospitals in the cities. This is negatively affecting the lower class who mainly live in the distant rural areas of China. In Mexico, the cost of getting health assistance is too great for the lower class. Because there is no universal healthcare system in Mexico, most of the money needed for treatment has to come out of the pockets of the less fortunate lower class. Of course, individuals of the upper class have the money to pay for their health needs, so they have no issues with the system. As a result, the system stays the same and the lower class continues to struggle. In Norway, the healthcare providers themselves were the source of the unequal treatment. For some reason, they felt that the people who were less educated deserved less treatment from them. Once again, because there were no negative effects on the upper class, the situation remained the same.